Hello, everyone. Good morning. I believe we can start. Welcome to today's session in the XYZZ CME series. My name is Lee Gitao. I am a sixth-year MBCHB student at the University of Nairobi, and I will be moderating the session. Before we start, I want to take a brief moment and tell you what XYZZ Med Education is all about. XYZZ Med is a growing community of Kenyan medical students from different universities who are committed to transforming medical education by creating accessible, locally relevant, and context-driven learning resources. Our work focuses on peer-to-peer learning, practical clinical relevance, and bridging gaps that exist when we rely heavily on foreign medical resources that may not fully reflect our local realities. Through initiatives like this CME series, medical illustrations, case simulations, quizzes, and digital platforms like JuveNotes, we are able to make learning more engaging, collaborative, and impactful for medical students and healthcare professionals across the region. We would also like to acknowledge and sincerely thank our partners who have made today's session possible. That is Dr. Online and JuveNotes, as well as MTV for publicity. Today's session will focus on fractures of the elbow, forearm, and hand. So we'll begin with a presentation, followed by a short interactive quiz on Kahoot, and then the quiz now will reinforce the key concepts that we learn, and then we will conclude with a Q&A session. So feel free to note down any questions that you will have as we go along. So without further ado, I'd like to introduce today's presenter, Isaiah Okumu, a fellow MBCHB Level 6 student from the University of Nairobi, who will be taking us through this important and clinically relevant topic. So Isaiah, you can share your screen and we'll start.
Hello, everyone. Confirm that you can see my screen.
Yes, Isaiah, we can see your screen.
So we have a lot to cover. I don't promise to finish everything, but let's say we have 60 minutes from now. So the topic for today is fractures of the elbow, forearm, and hand. And as you've heard, my name is Isaiah. I'm a level 6 student, so let's continue. Yeah, so these are the learning objectives. I'll not go through them because of time, but basically we'll do approach to an orthopedic patient. I'll show you the things you need to do, just an overview, not in-depth. An in-depth view, we'll find that in the wards. Or if you find me outside the library, I can be able to show you that. Then we'll also do a history exam, and then what you need to look for in a physical exam. We'll do principles of fracture management. Then we'll now have the foundation to continue into fractures of the elbow, hand, and arm. Yeah, so this is the outflow, just what I mentioned. So I usually start by giving out a case so that you have like something in your hand, in your head, I mean. So we have this patient, PK, 28 years male, motorcycle carrier, hand of dominance. So I hope you do know that you need to ask for the hand of dominance, the dominant hand rather, so that you're able to ascertain that the hand that you're going to be fixating won't necessarily cause any harm or stiffness or things like that, any complications to the patient. So date of presentation, 24th January 2026. So this is just a sample history basically that, so let's say this patient presented, so you start by mentioning this, and then if maybe they've not gone to the operating room, we can be able to say, okay, I wrote the DS today, so maybe they've not yet gone to the operating room. But this patient presented with pain, swelling, and deformity of the right forearm, 6 hours. That had been for 6 hours ago. So patient was previously well involved in a road traffic accident. You explained the mechanism of injury, hit from the side, fell onto an outstretched arm. There was severe pain, you suffered the pain, there was swelling, visible deformity, inability to use that limb. And remember, this is the right forearm, and he was right-handed. So pain is an 8 out of 10, constant, increasing with movement, reducing with immobilization, which means that once he starts moving the limb, it's when the pain is exacerbated. So he had no open wound nor has any active bleeding, associated symptoms, no LOC, no head, chest, or abdominal injury, no numbness, tingling, weakness, or coldness of the hand. So relative negatives, these are just some of the risk factors that, or things that could certain that they have maybe infection or something of the sort. So yeah, no bone disease or pathological fractures. And then I also forgot to mention here that sometimes you can also say like uh, for pathological fractures, you can have falling from a standing height. Yes. So no alcohol intoxication and is not a smoker. So what's an approach to the orthopedic trauma patient? So first, when you receive a patient in casualty, you do the ATLS protocol. Primary survey, secondary survey, airway, breathing, circulation, disability, the environment. When you move to secondary survey, the ample approach. So I think ample was allergies, medication, something last meal, and events leading to the which we've cited. So then administer analgesia early, and you explain the mechanism of injury just like we have done, and explain the dominant hand and the occupation. So as you can see, as you saw, we explained that the patient's dominant hand was the right hand, and his occupation is that he's a motorcycle rider. So already risk factor for forearm injuries. Yeah, so for the history, we've talked about obtaining the details about the traumatic event. Is this a high energy or a low energy? High energy would be road traffic accident. You can have low energy like falling from a standing height, which would be pathognomic for pathological fractures. We have things that exacerbate pathological fractures. Okay, I'll be talking, so most of the things are not in my slides, so I'll be talking if I think there's a recording. So some of the things like that can cause pathological fractures, we have bisphosphonate therapy, zoledronic acid. You can have malignancies. Some of the worst case scenarios are multiple myeloma. We can have prostate CA that mets to the bones. Yes. And also breast cancer. So that's one of it. So for the symptoms and the signs, so you assess for severe localized pain, inability to bear weight, visible deformity, swelling if you have crepitus to avoid intentional elicitation, and then also if there's tenderness over the affected bone. So for the physical exam, you can see here that I've written look. So examine the patient from the front, from the anterior side, from the lateral side, and from the posterior side, especially if we are looking at, let's say, the humerus or the elbow or something of the sort, like the hand. You want to ensure that you're looking at it from various planes. So you look for the attitude and posture, you look for the deformity. How is it angulated? Is there any swelling? Sometimes you can have clavicular fractures, which you can have skin tenting, which is basically the skin has been elevated by the clavicular bone, so it looks like a tent. You can also have um, swelling or edema. You can also have scars, sinuses, bruising, muscle wasting, and then explain the gait if we are talking about like a pelvis injury or something. Yes. So for feel, you want to feel for tenderness. You want to examine with the back of your hand the local temperature. Warmth might suggest inflammation, which is a characteristic of infection. So you can also look for swelling. Is it soft? Is it firm? Is it fluctuant? Uh, one of the one of my friends taught me how to actually determine what's hard, firm, and soft. So hard would be like your forehead. If you touch it, that's hard. Then firm would be like your nose. and then soft would be like your earlobes. So that's how you characterize swellings. Then crepitus, sometimes you might have the bubbles and popping and yeah. So bony landmarks and step deformity, neurovascular status. You want to check, am I bleeding? Okay, not me, but is the patient bleeding? What's the cap refill? Does the patient need any ATLS procedures? At this point, maybe let's say they're bleeding underneath and what's it usually called? I've forgotten, but basically you want to ensure that even they can feel. So you do your palpation, touch, 2-point discrimination. You want to know whether there's any nerves that are damaged. So for move, assess the range of motion. So first you tell the patient, can you move the joint? Let's say you're working with the shoulders. Tell them, can you flex your shoulder? Can you abduct your shoulder? Can you adduct your shoulder? Can you posteriorly, what's it called? Can you extend your shoulders? So after they are done that, you note that maybe there's no range of motion, or maybe in the initial 15 to 30 degrees of the shoulder, they're not able. So, maybe it's a problem with the supraspinatus. Passive movements, now the examiner moves the joint. So you help the patient to move the joint, especially if, let's say, that example that I've given, they're not able to move it within the initial 0 to 30 degrees that the supraspinatus works on. You would want to shift that and ensure that now within the first 30 degrees, you're the one and then you'll find out that, oh, after 30 degrees, maybe they're now able to move. So you comment on that as full, restricted, or painful. If there is presence of abnormal or painful movements, abnormal movements could be experienced in conditions like Ehlers-Danlos. Those conditions, connective tissue disorders, stability of the joint and functional movements. So this is for the neurovascular assessment of the upper limbs. You can have the median ulnar and radial nerves. So I didn't put up the image for the sensory innervation but you can look it up. The sensory innervation to the arm, forearm, and hand, just to note where if you injure the median nerve, where if you injure the ulnar nerve, maybe behind the medial column, some of the sort. And the radial nerve, the radial groove, what are some of the things you'll experience? Yeah, so for that, there's a mnemonic too, Dr. CUMA, drop radial nerve, C, claw hand, ulnar nerve, M, median nerve, and hip hand. So yeah, then you check for all this and document, and that's so for principles of fracture management. So this is where it's just getting exciting. So the thing is, when you're in the wards, one of the things you need to mention is that a fracture is not just a breach in the continuity of the bone. A fracture is a soft tissue injury, the breach in the continuity of the bone cortex. So there's a repeated, but I correct that if I send the slides. So basically, there's usually soft tissue injury with a breach in the continuity of bone. This is Dr. Mogire et al. Yeah, so that's the definition of a fracture. Then you want to classify it by skin integrity. Is the skin intact or is the skin communicating with the fracture site? If it's communicating with the fracture site, that's an open fracture. If it's closed, it's a closed fracture. So majorly you'll find open fractures being managed surgically. Closed can be managed either surgically or so we can manage, okay, a closed fracture, you can manage it using closed reduction and open reduction. We'll look into that. So by completeness, maybe it's not going through the whole context. We'll see what a green stick fracture is and the backward fracture is. These are common in pediatrics. Then whether a fracture is complete, so can be broken into distinct fragments. You can have a transverse, oblique, spiral, impacted, and comminuted. So complex fracture, comminuted fracture is a fracture that has more than two fragments. So it means that if you see three fragments in a bone, mostly you see like a butterfly pattern in that. I think I didn't put that image here, but basically you'll see three three fragments. That's a comminuted fracture. For a simple fracture, that's mostly two fragments. So what's the physiology of fracture healing? You can look it up online, the basic cytokines and all that stuff, but this is basically the flow. These are basically the stages. So we have hematoma formation, we have inflammation, and then we have soft callus formation, hard callus formation, and remodeling. Basically, this is secondary bone healing. For primary bone healing, it's basically the it's basically achieved using what's it called? It's achieved using um yes, surgery. You basically pose the bones with absolute stability to a point that you cannot have callus formation. For callus formation to occur, you need the bones to move a little. It's relative stability. We'll look into absolute and relative stability in the next slides. But basically, hematoma formation is the vessel's rupture leading to clot formation. And then there's a mesh. And then next is inflammation, where we have the cytokines appearing in the hematoma. Then we have the soft callus formation. In what you need to understand with this is that we have woven bone is replaced by lamellar bone. There's something called Wool's law, and I didn't write it here, but Wool's law is basically when you have what is it called? Pressure. Let me try and remember. But basically, Wool's law is the bones are becoming stronger and there's a lot of pressure. And this pressure is used to create forces that will be able to create this remodeling. So it's what is now going to cause the lamellar bone to form. So yeah, so that's basically it. Fibrocartilage formation, mineralization. So you can just check into the intricacies of the details. I was just mentioning this so that you understand when you're going to manage a patient with, let's say, if you're going to manage a patient with maybe a distal radius fracture or a proximal radius fracture, it depends with how they've injured their bones, and it depends with how you want to achieve healing. Is it by primary bone healing or is it by secondary bone healing? So these are the principles, the AO principles. This is the modern classification. I know someone will ask me, what about 4Rs? Yeah, resuscitation, reduction, retention, and rehabilitation. So I think that was the previous way. There's now the new way called the AO classification, the principles, the AO surgery foundation. So the principles that they've come up with is basically that you have reduction, which is just basically, if let's say you fractured your bone, I'll show you a picture, and you have it misaligned. You want to ensure that the bone is aligned again, its same plane and it's the same way it was rotated anatomically. So yeah, so majorly we do here we check, is it anatomically reduced or is it functionally reduced? The reason I'm talking about anatomical reduction is because for a joint, you don't want anything less than anatomical reduction. It's just you want it as stable as it can be. If your elbow is moving and it's moving in an adducted position, that's not good for your elbow. The carrying angle might be wider. You might have problems with writing if it's your dominant hand. So you want to ensure that you restore length. So that's for anatomical reduction. For diaphyseal fractures, we'll see how to determine the diaphyses, epiphyses, and all that. But for diaphyseal fractures, you can allow for some misalignment. That's what it's called. So you can have functional reduction. Then methods used closed or open. For fixation now is maintaining reduction until union. Union is just basically when the bones have now healed. And there are three of these. Non-union, there's malunion, and then we have delayed union. We basically say that a bone is non-united when it is 9 months post-op, there is no healing, and for the last 3 months, these bones have not shown any indication that they are healing. So that's what non-union would be. So fixation should provide adequate stability, not necessarily rigidity. So we have the method. So let's see now what's absolute and relative stability. So absolute stability is just when you achieve that anatomical stability. Basically, you want if it was aligned, it, if it was aligned the way it was aligned normally, like with the way you were born, that's what we want to achieve. Nothing less. We can't allow even a step, can't allow a rotation, a misalignment, or a malunion. For elbow, for knees, we want to achieve absolute stability. And this is achieved using primary bone healing, where there is no callus formation. Healing here occurs by Hervatian remodeling, and it's indicated in intra-articular fractures. For relative stability, you have a diaphyseal fracture. We'll basically put in maybe an external fixator, maybe a functional cast, a bridge plate. When we do that, we achieve it using secondary bone healing, where we see visible callus. Yeah, so that's for relative stability. Now the third is blood supply, which is preservation of blood supply. And basically, imagine now, this is the example I was taught in the wards. If let's say you're in the wards and you find 6D, you go to 6D, you'll be asked this question: what's the third principle of fracture management? Just start stating preservation of blood supply. I'll give an example, though we are doing UPPERLIMB. Let's say you're going to put in a plate and you're going to put in an intramedullary nail. You're going to be inhibiting blood supply because there's blood supply through the nutrient artery, which is going to go into the intramedullary region. And you can also have the periosteal arteries, which are going to supply the endosteum. So, sorry, which is going to apply the extramedullary region. So if you're going to put in a plate, you're going to be affecting the extramedullary blood supply. If you're going to put in a nail, you're going to be affecting the intramedullary blood supply. So the best case scenario for you is this, that you put up just one. As much as you want to achieve like absolute stability, sometimes you might be able to like think it through that what I'm doing might be able to cut off blood supply, and blood supply is needed for what's it called? Blood supply is needed for healing. So that's why you see here minimal invasive techniques like NIPO. It's basically when you're not just opening the whole limb, you just maybe cutting the proximal part and the distal part, and then you slide in your plate, and then the places that you can't, you just suture them again. So that's basically for it. And you want to preserve the periosteum. It usually comes with some blood supply, and we've seen this is the reason now we've seen physiology of fracture healing is because the hematoma and all that stuff is needed for healing, which is a principle of fracture management. Then after that, now you go to rehabilitation, which is early safe mobilization. You want to start moving the joint early so that you prevent joint stiffness, you prevent muscle atrophy and thromboembolism. Muscles have something I think they call physiologists call it use and disuse. Majorly, if you're not using a muscle, you find that it will soon atrophy. Yeah. So these are some of the fracture patterns, and we have a transverse, oblique, spiral. The difference between an oblique and a spiral fracture, I think a transverse fracture might be easy for you guys to understand. It's just a break in the continuity. That's like simple fracture. It's across, it's axial. We can have an oblique fracture. The difference between this is that a spiral fracture covers twice the circumference. Is it the circumference? It covers twice the diameter. So you'll see a cut. Let's say this is a bone. You'll see a cut like going a very long distance in an oblique fracture. So oblique fracture is just shorter. A segmental fracture is two segments we have a proximal end and another end, and we have one fracture line going through the whole circumference of the bone. I didn't write it here, but yeah, a segmental fracture is just that you have two fracture lines in one bone. Let's say you have it in the humerus, so we have two fracture lines in the bone, and then but one fracture line is covering the whole circumference of that bone. So you have like three fragments, example wise. A bone fragment is pulled off by a tendon or a ligament. Most likely occurs in the neck of femur, head of femur. Impacted fragments driven into each other. So you also need to describe displacement. So if you're given an X-ray, you describe okay, this is it. Where is it? You describe all this. You describe the patient ID, the date, the modality. Uh, if you go to ortho, if you want to sound smart, you can just say this is an orthogonal view of the posterior view. You can also have lateral view. So that's what you explain. You trace the cortical lines, you trace the bone, describe the fracture, the joint species. Is there subluxation? No. If not, is there swelling of foreign? Is there swelling of the soft tissues? Is there foreign bodies on the front pad? So if you come back here, now you want to describe displacement. And when you're describing displacement, there's a mnemonic I have that not necessarily going through with this, but it's STAR. So STAR, which is shortening, translation, angulation, rotation. So shortening is also lengthening. So you just state, is there any shortening or lengthening? Is there any translation? Is there any angulation? So you tend to, is there any rotation, which is twisting? So I'll show you an image. And you want to use the rule of twos, which is two views, two joints, two limbs, two occasions. Two views is AP and lateral. Two joints, the joint above and the joint below. If it's a humerus shaft fracture, you want to state the shoulder joint and the elbow joint. Two limbs, you can be able to compare with an injured side. So let's say it's the left humerus compared to the right humerus. Two occasions. So sometimes some bones like the scaphoid, you can find that when you take a view, like when you take a radiograph right now, it will be you might miss the fracture. But like after maybe 2 weeks, you can be able to, if you repeat an X-ray, you'll find that what the patient was complaining about wasn't just anything. So you want to check that. Yeah, so we talked about that. So this is the age of classification. So I can't pronounce that name. It's a Swiss name, I think, French name. No, a German name, sorry. So, but there are some Switzerland surgeons who came up with this classification and they tried to number the bones. So this is how it looks like. So the humerus is number one. The radius ulnar region is 2. 3 is for the femur, for his tibia. 5 was the pelvis. Oh, wait, sorry. 5 was the spine, and 6 was the pelvis. 7 is the hand. 8 is the foot, and 9 medial maxillofacial. So you start this way. Then after you're gone, then you come back up 5, 6. Then you come back 7, 8, and then 9. So then if you're going to be having, like, let's say a humerus fracture, you start by saying 1. Then you move to the next thing. Is this a proximal region of the humerus? Is this a mid? Is this a shaft, or is this the distal? So the shaft is also known as the diaphysis. So you mention 1, 2, 3. So if let's say you can see it, you can see it here. So the proximal diaphysis distal. So if this is the femur. So if it's in the proximal part, you say that this is a 3, 1. So you start by the bone. So you say the femur, then you say the 1. You say 3, 1, and then now you come back here. It's within because this is a diffusial classification. for the articular places, let's say like this proximal part, you'll more likely use another a way to explain them. But just for purposes of time, I just put up this so that you understand when you go and read for yourselves. This is what we call a multifragmentary. These are bending. So this is like a butterfly. This is the shape of a butter, like the wings. So this is how it looks like. So let's say you're in the diaphysis, this part. And how do we determine that you're in the diaphysis? You see the drawn squares. You take the longest part, the longest diameter, the widest rather, the widest part of the bone, you draw a line. Then you take the same line, draw it like a length or a height, how you want to describe it. So this is the width, this is the height or the length, and then you draw like a square. So anything outside these bounds, that's the diaphysis. This region, that's the diaphysis. So if you're in the diaphysis, you'll more likely see this. If you're in the diaphysis, you'll use this classification now. So you'll say it's either a simple, a wedge, or a complex. So let's say it's a spiral fracture that's in the it's a spiral fracture that's in the diaphysis of the humerus. So you'll say it's in the humerus, one. It's in the diaphysis, two. Then you come back here, you say it's a simple, because it's just this spiral. These are simple. One. Just two. Remember we said two fragments. So just two fragments. This one has three fragments. This one is complex. It has many fragments. Yeah. And it's basically it's comminuted. So this is what you'll see. So this is what you'll say a simple A1. So what you'll say this is a 1, 2, A1. I hope you've understood that. Then I'll now give you an example. For instance, this bone here is the radius. You draw your widest part. The widest part of this bone is here. If you draw a square, you'll most likely find that this fracture line is still it's outside the bounds of the diaphysis. You can see very well. It's outside the bounds it's still within the epiphysis. So this would classify in the another version. So it's still in the proximal part. So in the proximal part, you'll either say, is this extra articular? Is it involving the joint basically? Is it partially involving the joint? So partially, partial articular, or is it intra-articular? So you see, under the AO classification, so we'll say this is 2, which is the radius. Then we'll say this is 3 because it's a distal part. And then we'll say this is extra-articular because it's not involved in the joint. And then simple metaphyseal fracture of the distal radius. So that's how you classify it, 2, 3, A2. All right, so let's start with what was promised not to finish, but we'll see. You're halfway done. This is the elbow anatomy. What you need to understand is just the medial epicondyle, the lateral epicondyle, the cranial fossa, the ulna, and the radius. This from the posterior view, this is the anterior view. That's how you see it. The medial epicondyle, the lateral epicondyle, the head of the radius, the ulna, basically. All right. So if you have a supracondylar humerus fracture, we use some, I think somebody explained it's 5 centimeters above the joint. Yeah. But basically, that's where the supracondylar region is. So then, if you have a fracture line here, this is what we call the Gatland classification. It has 4 types, but I know I've written 3 types. Mostly 3 types is what is there in the I found an image online that shows type 4. So I'll explain both. I'll explain everything. So supracondylar fracture, just above the elbow joint, common in children. You see there's a fracture line here, but it's not displaced. You see there's a fracture line here, but the bit displaced. So that's why I went through the displacement. Now you can see there's a displacement. It's like it's angulating, but the posterior cortex is intact. If you can see, there's like some space here, but this posterior cortex here is intact. That's type 1. Now the difference between type 2 and type 3 is that this is now completely displaced. Has anyone seen that? So there's some space here and all that. For our type 4, it's displaced, but there's multidirectional instability. It's like swinging on its own. It's not that stable. At least for this one, it's stable. So type 4 is there's multidirectional instability. How do you manage a long arm cast or splint? This cast or splint it. The forces will enable you to achieve secondary bone healing. So for this one, you can do close reduction or percutaneous spinning. So that's it. Emergency vascular compromise. So you can have the brachial artery here compromised. The complication, median nerve or the brachial artery. So yeah, basically it goes to the anterior interosseous nerve, continues as the anterior interosseous nerve. One of the other complications would be malunion. So it's not united correctly. Yes, you've achieved healing, but it's not united correctly. That's what we call advanced stroke deformity. So this is a radial head fracture, basically classified. It's a fracture of the proximal radius falling on an osseous hand, which is also known as FOOSH or FOOSH. So type 1 is the fracture line, but it's non-displaced. You can see there's no displacement here, but for this one, you can see there is a fracture line, but it's displaced greater than 2 millimeters. That's type 2. For type 3, it's comminution. You can see there's more than 2 fragments. You can see there's only 2 fragments. For this one, type 4, there's a dislocation. So the dislocation is posterior. The elbow has gone posterior. All right. So how do you manage this? You can use slings for comfort. That's just this. Then secondary bone healing. But for the others, you might need to put in like screws or just put in a plate. Choose one so that you don't compromise principle number 3. Then there's also complications. So stiffness or heterotopic ossification. So for olecranon fractures, we use something. Okay, I forgot to put the image. Sorry, forgot to put the image. But it's a fracture of the proximal ulnar, the elbow joint, and it disrupts the extensor mechanism. So basically, there's usually an undisplaced, displaced stable joint and stable joint. And I'll show you the olecranon fractures later. But we manage it using a long arm cast and tension band wiring, which is a gold standard. One of the things here is usually there's ulnar nerve injuries, a lot of it in the olecranon fractures. So we usually have elbow dislocation. So there's shoulder dislocation and elbow dislocation. The most common direction for elbow dislocation is posterior. Elbow, posterior. Shoulder, anterior. So the way I've like mastered or crammed it is shoulder anterior, South Africa, SA, shoulder anterior, something of the sort. You can take away with that. So something you can have one of the complications. So this is how it's gone. So posterior. Always remember when you're talking about bones, we give more authority. Yeah, to the distal fragment. So this is the one that has gone posteriorly. And you can see it's almost, this is the end, like the skin. Yeah, so one of the complications is usually called a terrible triad, which is dislocation posteriorly. You can see it. If you have radial head involvement and the coronoid process involvement, so ERC. So dislocation, radial head, coronoid process. Hope you've understood that. Yeah. So this is the extensor mechanism is disrupted and surgery displaced. So under anesthesia, you disengage the bone and then you align it then you engage it. That's how it's done. So for forearm fractures, so this is what we call a Montegia fracture. So for Montegia fractures, it's just basically fracture of the proximal ulna and dislocation of the radial head. So this dislocation of the radial head, proximal ulna, sorry. So this is anterior dislocation. If you stand in anatomical position, this is anterior dislocation. This is fracture of the proximal ulna, which is the most common. Then we have type 2, which is posterior dislocation. So this you can see has gone posteriorly. Then this has gone laterally. So APL. So A anterior, P posterior, lateral. And then you have both bone fractures. Simple as that. The complication here is posterior interosseous nerve palsy. So the other one was anterior interosseous nerve, which was for the median nerve. All right. So what's a Galeazzi fracture? This is a reverse Montegia fracture. The mnemonic is that MUGR. So Montegia involves the ulna, a Galeazzi fracture involves the radius. That's what you can see here. So this is just a fracture of the distal radius and dislocation of the distal radioulnar joint. So you can see the dislocation here. That's basically what you need to know about a Galeazzi fracture. So these are managed using ORIF, which is open reduction internal fixation. So you remember we talked about reduction, and then you said it's just restoring. If you're going to be doing a closed reduction, it's you're manually using, or you can do a splint, a cast. If you're going to do internal reduction, um, not internal reduction, you're going to do open reduction rather. So we use said closed reduction, then open reduction. Open reduction majorly requires surgery. Then you put in an internal fixator. That's how it's done. So that's what ORIF means. Yeah. So if it's unstable, you pin it. Then you can also have restriction of supination or pronation. Remember the pronator teres comes around here and the supinator muscle is also around here. So that's why there's this complication of supination or pronation. That's basically that. So what's a green stick fracture? What's a green stick fracture? This is basically, you remember we said that two patterns have incomplete. No, we said that two types. So two types is either complete or incomplete. So under incomplete fracture, you say there's like something called green stick fracture. Then you also have a thorax fracture, which is also known as a buckle fracture. Basically, you can see the bone bending. And it's like if you take a green twig, those who have are playing when they're young, you could see like a green twig. It doesn't go if you try and break it, it doesn't break all the way. It needs multiple like times so that it breaks all the way. So that's how this is looking like. It's a green stick. So you can see the breaking the continuity here. So that's what this is all about. So it's an incomplete fracture. It doesn't go all the way of a long bone where the cortex on the convex side. You remember this is convex side break. So this is tension force, but the cortex on the convex side remains intact. So this is concave. And how to remember is that this looks like a cave. On this side, this is convex. And that's the breaking continuity. It doesn't go all the way. That's a green stick fracture. This is compression. This is tension. Basically, that's it. Immobilization in a cast. Close reduction is required. And the physician must break the fracture, break the intact process to correct the deformity and prevent recurrence of the angulation before casting. So it heals rapidly. For a buckle fracture, now buckle fracture is that you have axial loading. You have like a compression force. I'll show you an image that is trying to act from here. So you fell on an outstretched hand and it's the force caused an impacted fracture. So that's basically what this is. So it's also an incomplete fracture by a compressive load that causes the bony cortex to bulge. That's it. So for this, you look for a small bump and you can see the small bump here. You can see this image. This is a green stick versus a torus. So buckle fracture, the force came this way. Buccal fracture, the force came this way, axial force. This is what you look for. For a green stick fracture, it went, but it didn't go all the way. So on this side, we say tension, on this side, compression. For wrist fractures, this is the hand anatomy. So you can see the radius here, the ulna, and then this is the mnemonic scaphoid. So long to start from here. So long to pinky, phycatrum and pisiform, and then here comes the thumb. So the reason I love that mnemonic that is because it shows you the direction as well. So this is the pinky finger, this is the thumb. So long to pinky, here comes the thumb. So these are the bones. Scaphoid, lunate, phycatrum, pisiform, hamate, capitate, trapezoid first, then trapezium. That's it. That's what you need to know. So for Achilles fracture, it looks like a dinner fork. So you fell on an outstretched hand, and this is what happened. It broke and it went to the dorsal side. Remember, if you stand in anatomical position, this is the dorsum, this is the dorsal side, this is the volar side. So it got displaced to the dorsal side. So it looks like a dinner fork, basically. You manage it using close reduction and sugar-tone splint cast. Forgot to put what a sugar-tone splint cast is. Yeah, but you can check it out. Now, a Smith's fracture is now the opposite. So, a Smith's fracture is basically now the distal radius fracture with the volar displacement. It looks like a garden spade. This is the image. You see a Colles fracture fell and it went outward, so dorsally. This went volar aspect, so this is inward. So that's the difference between a Colles fracture and Smith's fracture. This went volar aspect, this went dorsal aspect. So this is a scaphoid fracture. Basically, there's usually pain in the anatomical snap box, and it has a high risk of a vascular necrosis. Why would you say that this has a high risk of a vascular necrosis? And then there's another bone. So if you had time, I would have told you to share which other bone. Okay, you can just write in the chat box which other bone has a high risk of a vascular necrosis and why. So yes, so there's this break in continuity in this bone, so scaphoid bone. So scaphoid, lunate, yeah. So it's simple. These are the waist. You use a thumb spiker cast, it's usually there. And the anatomical snap box, you need to know which contents, the boundaries. I think this one was key about that. The boundaries, EPL, APL, EPB. EPB is extensor pollicis brevis, extensor pollicis longus, backed up pollicis. Yeah, I've forgotten as well, but yeah. Then there's the contents, radial artery. There's also a boxer's fracture, fracture of the fifth metacarpal. This is the spot 1, 2, 3, 4, 5. This metacarpal, these phalanges, basically. You use an ulnar gutter splint. It's a result of this. A jazzy finger is basically a version of the FDP. This is the flexor digitorum profundus. So digits, these are the digits, and it's flexing. So it's a tendon from the distal phalanx. Patient cannot actively flex this joint. So it's common in the ring fingers, basically. If you see all these, they're like I actually thought this was hard. That's why I decided to do it. But if you just have like a good foundation of the AO classification, and then you have like a good foundation of what a fracture is, how the principles of the fracture management, it's easier for you to understand like where these things are, and then anatomy as well. So you see like a boxer's fracture, it's just easy. Once you see this, you just know next time this is a boxer's fracture. Once you see this, next time you just see this as scaphoid fracture. You see this, you just know if it's dorsum, Colles. If it's volar aspect, Smith's. This is falling on a flexed, this is outstretched. Outward, inward. Easy. Then jazzy finger, common in the ring finger. Mallet finger is basically a version of the extensor tendon. So remember the other one was the flexor tendon. This one is the extensor. So this, you can see these are breaking continuity here. And there it is, the extensor tendon. Just put an extension split for 6 to 8 weeks. Yeah. So in case you're wondering my study methods, I also have like a website where I study. This is like the website. It has like questions, so you can go through them. I'll send the slides. It has like questions. This is my study plan, a website I created. I think that's the reason. Yeah, so I'm done, and thank you very much.
Thank you very much, Isaiah, for that presentation. I now want to hand it over to Felix to conduct the next part.
Oh, sorry. Yeah, I saw someone had mentioned. Yeah, so it's the scaphoid, the talus, and the lunate. And the reason is because of retrograde blood supply. So yeah, thank you for your introduction.
Thank you so much, Isaiah. Confirm whether you can see my screen. Probably not.
Yes, Felix, we can see your screen.
Okay, great. Yeah, so for anyone who's played Kahoot before, okay, for anyone who hasn't, rather, so you'll just go to kahoot.it and then there's a pin that's going to come up on the screen. So you'll put in that pin. The quiz is from Isaiah, so just based on the presentation, hoping you're paying attention, just join it for fun. So 7427547 kahoot.it. If you remember, Kahoot is a function of both how fast and how accurate you are. So yeah, just to get you a bit excited as well and to revise. You're free to use your name or a pseudonym. It's up to you. So can join for the next 3 minutes and then we'll start. Let's have more people joining. It started exactly 12. So if you haven't joined, please join. So we start. And then I think Lee will now take us through the Kahoot.
Yes, like Felix has said, remember it's a function of how accurate you are and how fast you are. So try and answer the questions as fast as possible. So yeah, you will tell us when you start.
So it's 12. we start.
Okay, good. The first priority was airway maintenance. I see 14 people have gotten it. Let's continue. Yes, it is associated with posterior interosseous nerve paralysis. I'm also playing, so I yes, so yes, we can continue, Felix. We have MSN in the lead with 1559 points.
Next, I think I've gotten, but this is a ulnar collateral of the MCP. Next, Soja is leading, followed closely by A and orthobro. Next complication of Colles fracture. There is stiffness of fingers. Yeah, majority did not get that. Orthobro is now leading on brand. Next question. Jazzy finger. Just grab the jazzy. So jazzy finger, the FDP. A is back in the lead. Orthobro and double A following closely. Bado classification. Those for Montegia fractures. Majority did not get that as well. A is still in the lead, followed by Soja and Orthobro. But bad sign. radial head fracture. Okay, nobody got that right. So A still maintains its position. Terrible triad of the elbow. Radial head fracture, coronoid fracture, and elbow dislocation. The terrible triad. Four got it right. MSN has moved up, and Maurice is climbing steadily and surely. Nerve most commonly injured in posterior elbow dislocation. Well, majority got it right. There's someone who's, is it Apples? Yeah, Apples has claimed 3 places. Most important principle, managing growth bone and fractures. Maurice with plates. 4 people got it right. A is still on the lead. Maurice is now on the podium, coming in hot. Most feared complication of forearm fractures leading to severe pain and tense swelling is most everyone got that right. Compartment syndrome. A is creating a gap. Here's a streak. Okay, he or she. Which of the following most likely represented by, oh wow, with outside bandwidth. The scaphoid waist fracture, almost everyone got that right. QRS, and on the podium. Another image, most likely diagnosis. Galeazzi fracture, because it's distal. A is still on the lead. Soja QRS, that's our podium so far. Apples has a streak. Another image. Nightstick fracture. The majority got it right. I think we're almost for our last question. 15 out of 15. So the last question, according to Bado, Which type of Montague fracture dislocation does this injury represent? Yeah, nobody got that right. Bado type 1. So now it's time to find out. We might stop in third place. We have MSN. Congratulations. Second place, Soja. And our winner for today's Kahoot is A. Congratulations, and double A and QRS came in fourth and fifth, respectively. Yeah, well done to everyone who came top. Maybe A, you can say hi. MSN, Soja, B, you can say hi. Maybe tell us who you are and how you found the session as we congratulate you. MSN, Soja.
Hi.
Hi, Sharon.
Hi, how are you? That was a good session and Kahoots, and Isaiah's presentation was nice.
Thanks. Congratulations.
Thank you.
Soja. Or A.
Hello.
Lee, it's you.
Yes, I am A.
Oh, wow.
Yes, the session was very well. Concepts was very good. The concepts were very well explained. And yeah, congratulations to Isaiah and to the rest of the podium sitters.
Great. So maybe Lee, you can check if there are any questions and then we can wrap up the session.
Maybe before we close,
Yes.
the people were asking me what's the website about. So it's just basically, so I created a website that I usually put questions that once I've revised, I go and practice. So it has like MCQs, post key questions, and long case answers. So yeah, that's what the website is all about. So I'm just sharing it with you guys. So it's nothing. Yeah.
Thank you so much, Isaiah, for that great presentation and also for sharing. So we'll share the recording later. Thanks for joining. And yeah, hopefully see you next time for the next session. Have a good weekend.
Have a good weekend and thank you, Felix and Isaiah.